Hello, folks, and welcome to Transformed by Birth, a podcast about the rite of passage of pregnancy, birth, and new parenthood. I'm your host, Britta Bushnell, author, mythologist, childbirth educator, and all around deep diver with a side of goofball. I'm so glad you're here. Today's episode is all about thinking outside the false dichotomy box of either or, home or hospital, doctor or midwife. So grab your tea or take us for a long walk as we dive into collaborative care in birth. Before we begin, we start the way we always do by lighting a candle. If you want to join me, please do, or just take a breath as I light mine. Today's candle is in honor of collaboration. One of the most important decisions expectant parents face is who will provide their care. The spectrum of possibilities can be vast, from high-risk specialists to unattended free birth. But for many families, that spectrum isn't much of a choice at all. Instead, it's entirely dictated by insurance coverage, economic privilege, or what's geographically available. And when choice is possible, it usually means a trade-off. Opting for one type of care means opting out of another. But here's what's fascinating. Studies consistently show that integrated, continuous care between obstetricians and midwives leads to the best outcomes for both parents and babies. And those same studies also reveal that this kind of collaborative care is both extremely rare and difficult to achieve in our current healthcare system. So I guess you could say that my guests today are kind of a unicorn. And who doesn't love a good unicorn story? Dr. Bente Kaiser is a board certified OB-GYN with all the impressive education on her CV that you would expect, and then some. Sarah Howard is a licensed midwife and international board certified lactation consultant with a previous career in nonprofit and healthcare advocacy. In 2022, together, Bente and Sarah co-founded Moxie Birth, the only freestanding birth center in Los Angeles that was created and operated by a midwife and obstetrician. On a personal note, I am so grateful to be in local community with these two stellar professionals, and I'm thrilled to be able to share them with you all today. Welcome, Bente and Sarah. I'm so glad you're here. So,
Thank you for having us.
so good. So I want to talk about collaborative care and this unicorn that the two of you have co-created. But before we head there, I'm wondering if you could speak a little bit about what the more typical relationship is between OBs and midwives. You've each worked in the medical system for years prior to teaming up. What's happening there? Like when it's not this unicorn, what's going on? Talk about that. Sarah, you want to take that one?
Sure. Yeah. Thanks for having us, Britta. We're so excited to be here. I think there's a range of things that's happening between obstetricians and midwives across the United States, and we're pretty much talking about the US here, right? Um, I'd say at best, it's a hierarchical relationship in which obstetricians supervise midwives, um, typically in large systems. If a town or a city is lucky, maybe you could access midwives in a system that are supervised by doctors, which means that it's a very top-down relationship. Um, I'd say more typically across the US, there's very limited access to midwives. So midwives are not in every town and city, unfortunately. Juxtaposed to other countries where midwives are virtually everywhere. And I'd say the worst of this relationship, is full of animosity, mistrust, and competition in a sense. So what, particularly when we were talking about midwives who are working outside of the hospital, providing home birth or birth in freestanding birth centers, it's very challenging to find relationships with obstetricians that are collegial and respectful. So, and we need that because midwives are experts in normal. So when things are normal, it's very, very safe and it's well documented that it's safe for people to birth outside the hospital. But there are times when things become less normal, they become higher risk. And then we want really good relationships to be able to go into the hospital. And unfortunately, because of this sort of animosity between midwives and doctors, we often see gaps in access to those transfer situations or communication breakdowns once transfers happen, and overall feeling that doctors don't trust midwives and midwives don't trust doctors.
Yeah. And that can end up leading to care that is not good for the birthing families.
Absolutely. It has a huge impact on not only experience for the clients, but certainly for safety. So, and as you said, because we have all of this research about the benefits of the collaboration, it's just really unfortunate because it doesn't need to be that way. And that's what we're excited to talk about is another way.
Yeah. Yeah. Well, and that's what I'm excited to talk about as well. Um, Bento, what's your take on having been an obstetrician in a hospital? Like, how did you end up being like, hey, maybe I want to do birth outside of a hospital? Like, what this, because that seems so different than what it is that Sarah was just talking about of that more hierarchical. I mean, is what you're doing now, I'm asking three questions at once, but um, is what you're doing different than that? Talk to me about that and how that came to be.
So usually when I talk about how it happened, I always reach back to, 20 plus years ago when I was in residency, when basically when your doctor brain is being molded, right? And into what later might be a little bit how you're thinking about things. And my residency was a little bit unique. It was a small, high risk, high volume, community based hospital that happened to have a very thriving midwifery service, and we collaborated. And so that's how I was raised, if you want, as a doctor. I didn't know at the time that that was unique, right? So I just took it for granted, and I really enjoyed that collaboration. And I became friends with lots of the midwives and saw how we could do things differently. We even had water birth in my residency and all these things. And
That
then
is unique.
it
That
is
is
unique,
so different.
especially
Yeah.
because it was in the South Bronx, you wouldn't expect it there. And yet it was there because I think because the director of residency had been trained in Scotland, the UK. So I think he had already kind of an underlying knowledge of how that could look. What I don't understand is kind of like the opposite question. Like when we know that the evidence is saying that it's good for mothers and babies, it's cheaper, it is in every aspect, it is better. To have a collaborative care model, why are hospitals, insurances, you name it, why are they actually moving more and more away from that rather than towards it? That's what I don't understand. And then your third question, how it came about for me to do out of hospital birth, that was not the point. I didn't ever wanted to do out of hospital birth per se. That was not really my goal. My goal was to do births where people had options. And I found myself always very limited in the hospital, right? I was a kind of, I call it jail. Like I broke a little bit out of this labor room where you have to be in the bed to give birth, and it's like revolutionary if you do it on hands and knees or maybe in a side lie, like it's hard. And also there's so few options of movement and pain coping rather than pain control that you end up a lot of times with an epidural, right? Because there isn't really anything else offered because that's just how it is. And when you have an epidural, movement is even less likely. And so there is that kind of domino effect of what you end up doing is the same kind of thing over and over again, and you know it can be different. And so I was actually trying to get that into the hospital, but that was met with such enormous resistance. Like, you would think people always easily say evidence-based and mouth that kind of like as kind of an empty bullet point, but they're really not. And so I had a real issue with that, and I couldn't bring evidence in. Like, there was resistance against the actual evidence. And with that experience, then it came about that we could have this space at where we're at Moxie Birth. So it was more like an opportunity that rolled down when I just hit another, red tape moment in the hospital. And then I said, well, if we can't do it in the hospital, maybe we can do it out of the hospital. And so it wasn't really the goal to do it out of the hospital. It was just having the opportunity to labor and deliver in water, moving around, going at your own pace, not having a million interventions, not us telling the person that's in labor how to labor and what to do next, but kind of following along with that process.
So centering the parent, the laboring person in the ability to have choice, that you weren't seeing that in the hospital.
Yeah. Yeah, we don't see that in the hospital. We still don't see that in the hospital.
Right. And you wanted to really give options.
I mean, after 20 years of doing it one way, but knowing it could have been done differently, I really felt that I was just getting older and older, and I was going to eventually retire, not having really done it the way I wanted. It was a weird moment.
Powerful. And so then this space became available. And what happened next, Sarah?
Well, I mean, after so much banging heads against the wall trying to get this model into the hospital, it was just such a beautiful relief. I mean, I think our first birth at the birth center, doing it, Benta and I did all of the births for the first year, just her and I. And I mean, watching Benta receive her first baby in a birth tub
Yes.
was like so magical because and she was just like, her mind was blown, like, right, it's just as easy as I thought it was, and I've been saying all this time. And it is so quiet in the birth center. It's so intimate. It's so animal, like, even when it's not always like actually volume wise quiet, but it's like, it's just us. It's there's a relationship. So it was really beautiful to open that space and to just feel the relief of like, okay, yeah, we're gonna have to do this a different way. There's not a way forward inside the system right now, frankly, not in Los Angeles. And so we're going to have to model what we believe is possible, and that's going to be the way forward. And as practitioners, I would say it was an incredible relief. And then also it's a behemoth of something to try to model a new way, because it's in some ways, and I'll say in some ways it's not new. Like, it's really something that's being done in so many other places.
Yeah. Can you talk about that a little bit? Like, were there models for
Yeah.
you? Yeah.
I mean, to be quite honest, even in places like the UK, Australia, New Zealand, Europe, other places in Europe, the model is moving away from the collaborative care, right? And so we always refer to the UK or Scandinavia as the ideal places to birth because there is collaborative care. There was at least a tradition of there being a collaborative care model there, but that's also going away, just FYI. And I don't know why that is. Like, I talk a lot, of course, to my friends over there, and I don't quite see it. as we maybe romanticize it to be over there. So I think you really have to build your own microcosm, because there isn't a lot of, I mean, at least not near and right in front of me, there isn't a lot of examples that I can just name that this hospital is great or this birth center is great, or wherever you go, there's going to be issues, right? There are a few collaborative care centers where I feel that it really works well. There's one in India, for example, Sanctum Birth Center, that's run by an OB-GYN together with midwives. And there is a hospital in Madrid that has an OB-GYN that works with a group of midwives. They all have the opportunity to do it in the hospital. They have water birth, and they have also the opportunity to do a C-section there, you know? So that's kind of the ideal setting for me. So I think we have more a setting that is comparable with a community hospital, you know, like way, way far out in the boonies, where we don't have an on-call anesthesiologist. We have to go to a hospital, which then is 7 minutes away or 5 minutes, depending. And we don't have an NICU, and we don't have an OR, and we don't have a blood bank. So those are the things that small hospitals in the middle of nowhere in America also don't have. But we do offer, you know, normal labor. And we offer the opportunity to have a normal unintervened labor. And then when we do need more, we have to change location.
Like in a community-based hospital setting.
Exactly.
Yeah,
But
I
with the
hadn't
same-
thought about it like that, but it that registers, and you're also kind of fortunate that you're not in a community-based situation where the distance to that other kind of care is really long. You're
Right.
really close. You've
Yeah.
got a very short distance, should that need to happen. And even still, there's often a lot of indicators earlier on that a movement of location might be the best thing to do next. All right.
Typically, yes. I
Typically,
mean, there are
not
definitely,
always, of course, but
right. There are surprises, and you know, when you have a surprise in the hospital, I usually talk about perceived safety. I mean, there's my prime example of hemorrhage that I can bring up later, but perceived safety is the idea that you're always safe in the hospital, which is also not true. And you can have surprises in a hospital that no matter how many people are in that room or how high tech your situation is, you can't really save the day, you know? And there has to be certain humility, knowing that you cannot save everything in everyone, yet it's perfectly safe for a normal birth to happen outside of the hospital. And I mean, I can't prove this yet because we don't have enough births for that, but that the outcomes are very comparable to in-hospital outcomes, if not better. And we know that our C-section rate, sure as hell, is a lot better. So, you know, there's that.
yeah. One of the
And I
things,
want to
oh,
just
go ahead,
say
Sarah.
one more thing, which is that, you know, in the United States, we live in a world where going in the hospital is not safe for a lot of people. I mean, the vast majority of our country now is people of color, and it is not safe for them in there. So I think that, you know, for some of us, the hospital feels safe. It feels like a place where we associate safety. But for a lot of folks, it doesn't. It feels like a really scary place, and there's good reasons for that. And so I also think that remembering that when you bring birth back to the community, you're really empowering those folks to, you know, grow their own midwives and have a community-based system that's really going to support those families and is going to be safe for them, and congruent care with folks who live where they live, look like them, have their identities deeply understood in their blood. So I think, like, you know, coming at this from just this sort of lens of we all look at the hospital as safe. I think we just need to remember that we don't all. Like some folks are really desperately seeking outside of hospital options because that place feels unsafe to begin with. And then there's other of us who are like, we were raised to think that was the safest place to be. And so it seems crazy to birth outside of the hospital. In which case I often think about like the airplane car analogy, right? Like when you get in an airplane, it feels really crazy and like, oh, how is this possibly okay? And am I really safe? But honestly, being in your car every day is much more dangerous statistically. So there is a little bit of something to think about there with the hospital and being in your own community and outside of the hospital if you're really healthy and low risk. Because frankly, we are all animals. And if you look around at all the other large mammals, where are they birthing? Nobody's taking them to the vet after they've had their puppies or had their, foal. So, anywho, I just had to interject that.
I love it. And your analogy about the airplane and car is such a on point because as someone with flying anxiety, and yet I feel like a badass driver, and I know that the truth is not that.
Statistically, right? Yeah.
Yes, absolutely.
Yeah, for sure. A
And
lot more. Yeah.
yeah. And I also really appreciate, Sarah, that you brought up the idea of safety as a concept, that safety, it sounds like it's a universal, and it isn't. It's a perception and something that is felt, and how one develops the sense or the perception of their own sense of safety has so many different factors involved in it. And that's an important thing to be thinking about in regard to this whole conversation, which also brings me to thinking about the perceived sense of safety or expertise in regard to an obstetrician, an OB-GYN, or a midwife. And that for many people, they think of the specialist in obstetrics being an OB-GYN, a doctor.
Mm-hmm.
So you mentioned, Sarah, when you were speaking, that in some of these relationships between midwives and OBs, there's a hierarchical relationship. Now, you two are doing something a little different. What's going on here? I mean, I'm talking to quote unquote Dr. Kaiser, and I'm referring to her as Benta, her first name. So like there's so much to unpack here around even those perceived ideas of expert or specialist. What is your take on this? And how is it different? And why?
You want to take that one? That's I have lots of thoughts, but I wonder if you want to start, Benta.
I mean, I think that saying Dr. Kaiser doesn't make me any more of an expert than calling me Bente. Like, I'm the same person. I don't really feel that I need to like assert my expertise by having my credentials named every time you're calling me. I really don't feel that that's necessary. Um, I come from a place where physicians are often called by their first name. Like when I visit my friends back in Belgium or in Holland, they go by, they're often department chairs by now or whatever. And, it's like Saskia, you hear the nurses calling down the hallway. It's completely normal there. So it's kind of like it's a different place to be anyways. My brain is still kind of, a little bit there. And I find it much more comfortable there than in a place where we have to talk to each other differently depending on the credentials we've achieved.
Okay. And that's an aspect of that hierarchical relationship piece that feels kind of built in to the system, that so often doctors, as you put it, have their credentials announced, sort of, even just by referring to them by name. But there's
I mean,
more than that you two
there
do, right?
is.
Yeah.
Like I've heard colleagues say, "Oh, we have studied so much longer. Who are these midwives think they are? Like doing this at home and then bringing these patients to me, and now I have to fix it, right?" That's like that's that negative, that the extreme negative relationship where there is this balance back and forth that makes it worse on both sides. There is this dichotomy where the midwives, the out of hospital midwives, perceive the hostility in the hospital as difficult to transfer to, and so that makes the transfer threshold really high. And so then you're going to either go to a hospital that's farther away that you think is more friendly, or you're going to wait to the last minute where you really don't have a choice because you just keep hoping it's going to turn around, but you really kind of deep down know you have to transfer this patient to the hospital, right? And so by the time you actually arrive, that patient should have maybe been transferred sooner, but really if you look historically, the transfer didn't happen sooner because there was not a friendly reception. But now it's late, so now that reception is extra hostile, and so that really reinforces the bad relationship on the other end. So there is that relationship, and you have to completely break it down before you can rebuild, right? So we have to, in my opinion, be kind of eye to eye as humans if we're going to do something that is this high risk, basically, and it can go lots of different ways where maybe my extra knowledge needs to come in, or maybe also not, where I can totally step back and not need to be involved at all. And for the patients too, you know, in my other practice that I had where we all delivered at the hospital, a lot of people would come and say, oh, I want to come to you at the birth center. And I was like, you're not coming to me at the birth center. If you're coming to the birth center, you're coming there because you want an out of hospital experience. And the less you see of me, the better, because most of those can be done by the midwives and will be done by the midwives. And so that kind of like, I saw that as an eye-opening moment for a lot of my clients from then, that they were like, oh, okay, that's like a whole different concept. And some would take to it and be very positive, and some were like, okay, but that's scary to me. And that's totally understandable too. That's too new, that's too different. I haven't seen that model anywhere before. And I mean, that's kind of like the hard part about what we're doing is, you know, there isn't all that much examples around us. So we have to constantly really feel comfortable in what we're doing, and then back to that human connection. Like I need to really trust everybody on my team. I need to have a relationship with everybody on my team. You know, you can never actually cut a corner, like ever, as far as going all the way with a human relationship when you're doing what we're doing, I feel.
I also think we have to remember that like there's a really long history here, a strategic institutionalized history of you know, bias. So basically, like when you think about, I just did a training and heard a great example of implicit bias. Like when I say peanut butter, you think jelly, right? And it's because it's been over and over and over they've been associated. And the trust in doctors has been taught, it has been marketed, it is like the best branding campaign in the history of the United States when doctors came along and said it's safer to do this with doctors and took this from midwives. Like let's not forget that midwives were the provider for all birthing people for the vast majority of time. And so, and in every community and in every country, and right. So, over time, there's been this institutionalized, structured, you know, association between safety and doctor, the white coat, the marketing, all of it. And I think that when we go back to like, why do we call her Benta, is because we have to start stripping away all of that marketing and branding about what is safe and who you should go to and how you're going to be, what's fancy, you know, what's best, and really look at ourselves as we're all experts. The parent is an expert in their own body. You know, I am an expert. I've watched hundreds and hundreds of people from the beginning of their labor to the very end of their 6 weeks postpartum, right? When Benta and I started collaborating, that's not something Benta got to do in the same way. This intimate continuation of care with the same person over and over and over again. But I have never done a cesarean section. I am not going to scrub in on an OR and go do that. But Benta that's her expertise. So I think of this other analogy with this around looking at a room from the perspective of an artist or an engineer, right? We need both to build the house. Like,
Yes, I
we
love that.
like
Yes.
and it isn't that one is more valuable than the other. Like without the architect or the artist or and without the engineer, like you really literally need them both. And for us, you know, in a lot of ways, and I know there's a lot of folks out there who think, actually, I don't need either. If when it comes to birth, I'm just going to birth at home by myself. And that's also a choice you can make. Absolutely. But I think for us, when we think about the systems of birth in the United States, like we want to see a place where we've got the engineers and the artists, and I don't know who's who. I'm not trying to say the midwives are the artists. I'm not trying to say that. But you know, we need that to build these beautiful houses. And so we don't want to be reinforcing these hierarchies and these marketed, you know, I don't even know what was marketed that the doctor is the safe one. And so even just calling her Dr. Kaiser, it just reinforces this paradigm. Um, so it's really important, and we correct people because some people feel really weird about it. They're like, I should call her Dr. Kaiser, and we're like, no, no, she's a first name like the rest of us. It's all good. Like she doesn't really want to be called Dr. Kaiser. It's weird.
I mean, it's honestly crazy that it has to be such a big deal. And then it would be easier if my name was like Anna or Jane, you
Mhm.
know, where they're like, am I saying it right? You know, that was the other part that is like, ugh.
Yeah, but we can learn. We can
Yeah.
all do
Yeah,
hard
it's not a
things,
big deal if you
and
even
it's
said it
great.
wrong, right? But
Yeah,
it's really awkward sometimes that you can't just be Bente in a space where you just do what you do.
yeah. But it means something to us. Or to me, it really means something about what we're trying
Mhm.
to do because I feel that way in my relationship with Benta. I have never ever felt like Benta was like, I'll tell you how to do this now. That
Mhm.
is not how we roll. And it's because it's really, we just have different skills. Like we have different perspectives, not only just as human beings, but because of our training. It's just very different to train as a midwife than to train as a doctor. And folks don't necessarily always know that difference, or they wonder about midwives and doulas, like what's the big difference? And you know, that stuff is really we could get into that if you like, but you know, doctors and midwives are both medical providers. We're there to safeguard like the physical and emotional, you know, psychological, all of it, safety of the person birthing and the baby coming. And that's our job. I'm licensed by the medical board, so is Benta. And doulas are there as, you know, physiological and psychological and emotional support people. They are not medical providers. But even when you look at the medical providers of doctors and midwives, it's such a different skill set. Like Benta is a surgeon. If we have a really complicated laceration at a birth, I want to call her because she's an amazing surgeon and she is going to repair that beautifully. And we all learn from her and she teaches us classes. And those are different skills that we didn't learn in midwifery school. But a lot of times in the arc of a normal birth, you know, we'll know before Benta when we need to go to the hospital. Like Benta will be like, "Oh no, it's probably fine. You know, this is okay." And we're like, "This just crossed the line. This is, you know, this is the difference between working hard and suffering." Or like, "This is
Mhm.
gonna need, this is, we can, you know, sort of see down the road." And it's just because we've watched hundreds and hundreds of them outside the hospital. So it's not that we know better, it's just we know different. And to working together, that's such a beautiful thing because if we have doctors and midwives who are working together, then when you need to change location or you need to change, you know, you're sort of, you can slide in and out of needing these different things without being traumatized because so much of what is happening in the US in birth is traumatic. People not being seen, not being heard, not you know, it just feeling like their sort of decisions are being made about and for them. So yeah.
I think a huge lack of our training, you know, as OB-GYNs in the United States and also elsewhere is the lack of seeing physiologic birth. And I told Sarah that too, you know, the first time we had a couple births at the birth center after a while, I was like, I have never actually seen physiologic birth before this, you know? And that sounds really crazy, but I would say 99.9 of OB-GYNs have not seen physiologic birth. They have seen unintervened birth. They have seen, you know, unmedicated birth in the hospital, but they haven't really seen physiologic birth. And I think
How,
it's true. I haven't.
unpack those for us so folks who are listening can understand what you're saying about the difference between an unintervened birth and a physiologic birth. What did you see that was so different?
Well, physiologic is when you just let it unfold without doing anything. And, everything you're doing counts. And I think that at the hospital with cherry pick, right, it doesn't count to us that that person had to walk all the way from the ER to labor and delivery because it was past 10 p.m. or that she had to stand at the front desk and give her ID and tell them what her, driver's license number was while she was like breathing through her contractions. And even unintentional things like the smell of the hospital, the brightness of the hospital. You're still walking through this long, strange corridor hallway where you haven't been before. And then you end up in a room and you're basically being told a couple things. You're being told to put on a gown. You're not being asked if you want to, or if you brought something, or if you're okay with this, or if it's a good time. You're basically being told you're going to change into this gown. You're giving me some urine in this cup, and I'm going to take your vital signs. And then I'm going to start an IV. And it's all without any kind of interaction with the person in labor. It's just like, we are doing this because you're here now. So those are all interventions already, because a lot of people consider like a pelvic exam an intervention, or pitocin augmentation an intervention, or an epidural intervention, or breaking the water. Those are more aggressive interventions, more invasive, but it's already an intervention to drive to the birth center. So there's that too. So I think true physiologic birth probably is what happens at home. And I haven't been there. I haven't done a home birth or attended a home birth in my life, but as close to that is when you come to the birth center and it's dark and you just labor on. And we do also do your vital signs, but we do it when you're ready. We listen to the baby, but we don't have you on your back for that necessarily. We don't tether you to anything. We do it with a Doppler. And those are again, they're interventions, but they're a bit softer, right? So they're a little bit less invasive, if you want, of the sort. And that allows that physiologic process to continue uninterruptedly. Because it's not for nothing that a lot of people go to a hospital with roaring contractions and then get there and stall out, right? Because the smells, the light, the disruption, the talking to this person in their bubble kind of makes that oxytocin flow really halt, and you get more into fight and flight. And so you're not going to continue that physiological process, because now you're being asked to get into bed. Basically, you're not being asked to get into bed, you're being told to get into bed. You're given very few other options. Even if they were to say, oh, but we allow you to walk around, it's not like they encourage you to walk around. Like, they don't encourage you to do what you want. They encourage you to do what they want, because it's part convenience, and it's part also because there is like a continuous understaffing at every hospital. You don't have one nurse for one patient. That is utopia. That's unheard of. That doesn't happen. So you have one nurse for maybe 2 or 3 laboring patients. Unless they're pushing, then they get to give up their other patients, which means the other nurses have more patients. And so then it's much more convenient if you can tether all the babies to the monitors and then see them all at one monitor at the front desk, where you don't have to be in the room all the time.
Yeah, boy, that really lands as I think about my experience as someone attending births in a doula role. I even was just rethinking some of and I'm going to put it kind of in air quotes, the least interventionist births that I've attended in a hospital setting. One of them involved me sitting in the waiting room for 30 minutes while the couple was in triage.
Yeah.
And that was a form of intervention. It was a fantastic birth when we think about like the birth and how they felt about the birth and so many different things. It would go in the category of a quote unquote natural birth in a hospital and got so much of what they wanted, but they also got separated from me. They had this 30 minutes where they were poked and prodded and engaged with and stripped of clothing and put in a in closed by curtain, little partitioned area in a room with a lot of other people prior to going into their room, where then magic was able to happen. But all of those things that happened prior to them going in there really was shifting so much of what was occurring already.
I'm not dismissing hospital births either, you know, like it's not
Of
like that
course.
at all. But it's just like I like people to have the options and to unfold. But you also like the difference, but you ask what is the physiologic birth process, you know, and what are we interrupting here? Of course, it can still happen. I've done it many times too, you know, and I've been in that same position as a birthing person myself, but it still could have been maybe different if you
Well,
had
I'm
had
hearing,
more
yeah, that
options.
there's a spectrum here of what
Yes.
it is that we're talking about, and it's often spoken about in a more binary way.
There's also this idea in obstetrics that I mean, there's not even the idea. It is just more like a habit where we take things away and then we give it a name and offer it back. Like we're the grandiose people that are able to give you these things. For example, I'm going to delay your cord clamping. But, you know, instead of asking, what is the evidence for cord clamping in the first place? You know, am I allowed to clamp your cord? No, I'm going to allow you to have a minute before I clamp your cord, you know, because that is the optimal cord clamping time, according to some studies, right? Some other studies say 5 minutes, some say 2 minutes. Like there's like zero consensus, to be honest. And why are we clamping the cord at all? Like, do we really have to clamp the cord? What is the evidence for that? Another intervention that we're doing that we're like magnanimously now giving you some time before we're doing it. The same thing is with the golden hour, right? Like we made that ours to give to you, whereas it's your baby. Can I take it away? Am I allowed to take it away? Because I would like to weigh, measure, and do whatever with this baby. Are you ready for me to do that? You know, instead, we give you magnanimously the golden hour, and oh my gosh, aren't we so great for doing that? And so I have some issues with that kind of stance, and I see it more and more because I'm seeing it from the other side. Like, why are we doing these things? Why
Oh,
are we?
I love this. I love that you're shining a light on this, Benta, about the sort of repackaging in this magnanimous way of something that should be questioned from the get-go.
Yeah.
And just for folks who are listening who may not know what the golden hour is, it's kind of that place of that time after, immediately after birth, where often in a hospital setting or in different settings, it's like, we'll leave you for this hour to bond with your baby. And as if it's something that isn't just a part of what can be true, it's now being thought of as here you go. Yeah,
Mhm.
this is
And I'm always so excited when I hear other practitioners that are flipping this script. I saw there's a great um, Dr. James McKenna, who does a lot of safe sleep research. And I saw him speak, and he said, you know, mothers always ask me, is it safe for me to sleep with my baby? And he says, I always say, is it safe that we stopped sleeping with them? You know, that's really the question. Like that, you know, we kind of have to take a lot of this back, and unpack how it was marketed to us. Like how we are animals. We really just are. Like we are more akin in birth to like a horse or a cow than you want to believe, or a monkey. And, you know, when I think about like that hospital scenario that Benta was just describing, I think about how, you know, we really take comfort in relationship as human beings. That's you know, and we're not unique in that. Other mammals do that too. But in that scenario of going into the hospital and sort of having all of the things about the hospital impact your nervous system, I think about how could that look different in the system of the United States if we really integrated midwives into that system? And there are places in the country where we have that happening, especially on the coasts. We have more in large like metropolitan areas, we have more midwifery groups in hospitals, and people get to build relationships with those midwives in their prenatal care. And then when they get into that room, even if they had to go through the 30 minutes in triage and somebody's asking them their pre-pregnancy weight while they're mid-contraction, or what was your first day of your last period, but you're in
Or
These
was this an abortion, or was this a miscarriage? Like, it makes a
right.
difference.
But if you can get through that and you can get into the room, and then someone walked in who you had built a relationship with, and you trusted them, and they knew what physiologic birth looked like, and they were an expert in that care. Your nervous system could relax. You could come back down from fight or flight, and come back into your body and feel supported and have a medicated or an unmedicated birth with a low risk provider in that system. And then if you had a really great collaborating physician, if things become higher risk, that person can come in, and you can work together. And that doesn't mean then the midwife's out and has to leave. It just can mean like, okay, now we're going to look at this issue together and we're going to tackle this together. And that's kind of the world we want to see. Like, we know that we can our model is hard to scale, where we have a freestanding birth center with midwives and obstetricians working together 5 minutes from a hospital with admitting privileges. Like, this is a little bit of a unicorn.
It's a bit of a unicorn, yeah.
But what we know is possible is to build on the model that is popping up. There is so much interest in this. I mean, I was in midwifery school, I think, when The Business of Being Born came out, that documentary that really helped the pendulum start to swing about it for in the United States. Folks started being like, oh wait, yeah, I have options, right? Like, this is a business. Let me look at this differently and let me think about what's safest and best for me. We're seeing a lot more demand from people who are pregnant, that they want different things. Like, they want more intimate relationships with their providers. They want um, some of these basic things like dimmer lighting or not being put in stirrups when they push their baby out.
Or not
Very,
wearing a hospital
yeah,
gown.
not wearing a hospital, not just simple, honestly,
Simple, like cheap.
humanizing things. These are not things that make it less safe. These are things that just make you feel like an actual person who's bringing their baby into the world. You're not going in there to get a colonoscopy, like, you're going in there to bring your baby into the world. And the reverence for that is another thing that I think midwives are taught. It isn't frankly beat out of us the way it is out of doctors. And I think we should take a minute just to say that, like, that is a thing, that the training of doctors in the United States is also inhumane. And then we expect these people who've gone through essentially like a military style training and have been totally dehumanized themselves and torn up. We expect them to come out and be compassionate, thoughtful providers. It's also absolutely problematic. So we really need, and we see there being some more limits on their hours and things put in, but like, as humans, we just like tear each other apart in all these systems, right? And with birth, like, it's so detrimental to the people who are having their babies for them to be in systems like that are full of traumatized people. And so that is to say, I think, we have to start with our training programs. We have to start with looking at like how we can humanize everybody, and honor everybody more. And it's a huge undertaking for sure, but it is so possible to make really big impacts on clients and people with pretty small changes. I mean, if you look into midwifery groups like in your own home area, in hospital settings, like, a lot of times some of those changes they're happening.
Yeah. Yeah. I mean, some of the most rich, meaningful, tender birth experiences I've witnessed in a hospital setting have been under the care of collaborative team. and really amazing, because I'm also noticing that in a hospital setting, sometimes when there are midwives there, they also impact how the nursing staff operates. And one of the things that is kind of not expected by a lot of people who are going into their first birth in particular is how much the care they're getting in the hospital is not from their primary care provider or their OB or their midwife, but is actually the nursing staff. And when there is a midwifery team as part of the staff in the hospital, there is a way that that can influence how the nursing staff operates as well.
Well, 100%. Because if you've done something for 20 years and you've only watched that done a certain way, you're not even going to know that there's another way to do it necessarily. So if you have been an L&D nurse for 20 years, but you haven't seen physiologic birth, I've had nurses that tell me, I don't believe in that. I don't believe that exists.
Like
Yeah,
it's
because
like
they've
it's a
never.
belief, like a fantasy.
Right. Well,
Yeah,
because yeah,
okay.
like that doesn't really happen. Like if I let it be, it wouldn't really happen the way you say, because they have never seen that. And I really don't blame them.
Yeah,
I mean, that's a very
yeah.
honest stance to take, quite honestly. You've done it for 20 years, so you think there's nothing you haven't seen.
But
But
it's also tragic. It also
it's super
hurts when you say
tragic, of
that. Like
course.
I understand it
No,
and it
it's
hurts
sad.
my heart.
Oh
Yeah.
yeah, mine too, which gives me this intense desire for them to come and see it at the birth center, like come see what we do. But I mean, already changing things like not taking the baby out of the room when I'm doing a C-section is apparently like rebellious, right? Like, why are we doing that? But if you do certain things, always. And every doctor is like, yeah, this is how I want it. Like, take that baby out of my room when I'm doing a C-section. When the baby's out, I don't need that baby in here anymore. Because if it's a family that's just, had a baby. But that is what's happening all the time everywhere. And the nurses about the stirrups, I have to just go there because I find stirrups, they're great practical things to hold your legs when you have a heavy epidural and you need a repair. But if you're birthing a baby, even if you have an epidural, you can still usually move a little bit. And that can be quite helpful when you're pushing. We can then turn side to side, or you can get your legs, or I mean, whatever it is we're doing, we can do something rather than you just have your legs hanging in those stirrups, which is so standard. As sometimes when I come late to a birth for whatever reason, because it went fast, the stirrups are already out, the legs are already in the stirrups, and I'm like, we're doing this really, like, that's how it's been seen and taught and modeled, though, year after year after year of their working experience. I'm not blaming their nurses.
Right.
That's what they see all the time, which again brings me to like training and especially for residences around LA. I mean, my biggest wish is that some OB-GYN residents would come and do a rotation at their birth center and see something different. Because if you can plant the seed of someone, if they can see that it is possible, then they can believe, and then they might aspire to do something like that in the future.
Oh, yeah, absolutely. Love that dream. And I'm thinking a lot of, that a lot of my work is about rites of passage and the transformative aspect of going from individual to parent, going through the journey of birth. And this, when you're speaking about this different kind of way of holding birth and supporting birth, what difference do you think that makes on the transformation for the individual? Like Sarah, you sort of started to kind of speak to that a little bit in talking about ways that it's happening, and the individual, even the transformation for the doctor going through medical school has a kind of dehumanizing transformation. And now when we're talking about a different kind of care, let's refocus on the individual giving birth. How's it different for them in a collaborative care model? Sarah, you want to start on that one?
Sure. Yeah, I mean, we talk a lot about, like, or I do, about becoming a parent, especially that first time, as like a massive puberty, right? Like before puberty, you saw the world one way. After you go through puberty, you see the world totally differently, and you're like, oh, there was this whole other thing happening out here, and I didn't even know. And having a child is sort of like that. And I think, unfortunately, people end up doing that. They're very alone in that process in our culture. So maybe they have their families and whatnot, but there aren't care providers who are really connecting with them about that. So I think that's the biggest difference in midwifery care, but also in collaborative care. Having relationship building, like that's what humanizes everything is relationship. It's how Benta and I got here was our relationship that we made. It's how we break down some of these barriers in systems is by building relationships with each other, building trust, right? Just seeing where we are now from since we opened the birth center with the trust with the nurses at the hospital that we go to versus where we began when we first opened, like that trust is everything. And so I think um, for people who are walking through such a vulnerable time, having providers who they really deeply trust and who are going to see them all the way through is everything. I mean, it is the really truly for me the difference between um, having something be hard and having something be traumatic, because we can't predict where anybody's baby's going to come out of their body. I mean, frankly, I can't look at you and tell you, yes, you're going to birth at the birth center, or you'll be able to stay home and birth, or you'll end up in the operating room with a cesarean. There is no way for us to know that. Like, if we could have that crystal ball, that'd be so cool. But in some ways, it's really, really part of the magic that we don't.
Yeah,
And
exactly. I was going
right,
to say maybe it'd
yeah,
be
I mean,
great
it
if
would
we
be
had the
so
crystal
A
sad
ball.
if we
hundred
could know.
percent. I
Yeah, it
don't
would
want to
be
know.
terrible if we could know, because the whole thing is the journey,
Yeah.
right? The whole thing is the process. And so in our model, people never transfer out. They never have to leave their team. Their team goes along with them the whole way. So whether or not they birth in the birthing center or we end up in the operating room, they still have the people that they built the relationship with. And that's to me, that's everything, because a lot of times the folks who do end up with a C-section in our care are some of the ones who rave the most about what they experienced, because we just need to be honored and heard and respected and treated like human beings with the ability to make decisions even when we're working hard or going through something challenging. And really just in our system, people aren't treated that way.
I also want to add to that because you're asking what is the like what makes that how does that make like that transformation from birthing person to parent, ultimately that person brings the magic. It's not us that's bringing the magic and doing it so special and now you have the special birth. It's really whether you have your baby in stirrups, okay, with the hospitalist on call, it's fine, you're a badass, and it's the magic that you're bringing to that moment. It's just so much harder for you to do it that way, and we are trying to offer more pathways and more little ways to do it, not that one way that you have to fit into this one way. That's all. But ultimately, it's them that are bringing everything to the table. We just try to honor it as much as possible.
And remove some of the barriers.
Mm-hmm.
Because
But
there's
it's
so
not
many barriers. There's so many barriers to being able
right.
to access your magic. Like, your magic is going to be popping at home, maybe in early labor, because you've done all this prep and you've done all this stuff, and you're on the phone with your doula if you're lucky, and you're like, if your doula's coming over, and now you're making a plan to come in, and then you're going to just hit all these opportunities, unfortunately, for the magic to like fizzle because your adrenaline pumps up and your cortisol pumps up, and our system is really challenging to navigate. Um,
Mm-hmm.
and
Yeah.
I was a home birth midwife before I became a birth center midwife, and you were talking to somebody who had two surgical births. Surgical birth can be really traumatic, and it can also be really magical. Like, there is no one way to do this. It's really about the process. And that for me is everything. Like,
Yeah. Yeah. And I agree.
So
I
sad, yeah.
concur as in the work that I've done and the folks that I've supported and worked with, there's so much power in the individual and their journey through it. And I love how both of you and your team, because now you've expanded. I mean, you started off, it was the two of you, but now you have more midwives. I mean, I know you've got the remarkable Jessica Diggs. Do you have more than Jessica now?
With
It,
Julia Underwood.
mhm.
oh, yes. Okay. Um,
We have an
yeah,
awesome student, Anaí Sanabria, who just finished midwifery school. We have another student coming on. Yeah, we have.
you're deepening and expanding. That's
Definitely.
amazing. It's amazing. Well, so how do folks learn more or connect with your work if they're not local or if they are local? Like what are the best places to learn more about you both?
Yeah, you can follow us on Instagram at Moxie Birth. We're at Moxie Birth. I'm Los Angeles Midwife on Instagram. That's a good way just to see what we're up to and follow along. And a lot of times folks will send us messages saying like, "Do you know anyone in, North Carolina?" And we know a lot of people, so we're always happy to try to connect folks too.
Okay. And your birth center, Moxie Birth, is tell us just a little bit about where that is, and if local folks to the LA area are interested in that, how do they find out more about that?
Moxie Birth is in South Pasadena. It's about 5 minutes away from Huntington Hospital. And they can either email info@moxiebirth.com, or they can go to moxiecare.com and look at the website, or they can just give us a call.
Love that. So, as we begin to close our conversation, I like to end with the same question every time. So, are you ready for our final question? Okay.
Mhm.
What's one thing you feel passionately about that you want new or expectant parents to see, hear, feel, or know during this profound period of their lives? What do you want to highlight for them?
Um, after serving so many families and walking alongside them, I am more convinced than ever that people know what's right for themselves and for their own bodies and families. On a deep level, you do know what's best for you. And yes, there are experts out there and there are people, but everybody's going to give you an opinion. And ultimately, like from choosing your care provider to like choosing diapers or like choosing whatever, like you know what's best for you and your family. And I'm a firm believer in that and hope to empower people to find what is their own path.
I love that, Sarah. Thank you. Benta, what about for you?
I think that I would like for people to know that there's not just one way to do something, that there is a million ways, and that your particular birth hasn't happened yet. And that, not there's no two different births, two same births. And so how you want to do that birth, you're going to figure it out. You're going to do the right thing. Like Sarah said, you're the expert in your own body, but it hasn't happened yet. So there's no precedent for what is the best, and what's presented as evidence today may not be the evidence we're looking at tomorrow. So, what they're telling you and are adamant about, just take it with a grain of salt and look what else is out there.
Mm, I love that. Thank you to both of you, Sarah, Benta. I'm so grateful to have this time with you.
You too.
And thank you, listeners, for sharing this time with us. If something today that was shared impacted, supported, or moved you, please share this episode with a friend. I produce this podcast myself, and your support makes it possible. To show a little love for the podcast and these conversations, please follow, rate, and review. If you'd like to continue the conversation, please join us on Instagram at Transformed by Birth. I look forward to being with you again on the next episode of Transformed by Birth. Now let's take a moment and gather what you want to take away from this conversation with an inhale. And as we exhale, I'll blow out our candle. Until next time, bye, friends.